So thank you, Rebecca, for accepting to give a talk today. So for those of you who don't know you, so I will make a short introduction. So Rebecca is a professor of pediatric neuroscience at the Department of Pediatrics at the University of Oxford, and she is also a professional fellow at St. John's College. So Rebecca studied physics at Imperial College London and also neuroscience at UCL, and she has been leading the pediatric neuroimaging group since 2013. And her research goal is to understand the mechanisms that drive the development of pain perception in the human infant. And for that, she's using advanced neuroimaging techniques like MRI, magnetic resonance imaging, but also EEG. So the talk will be recorded, so available on the CEA website. And I would like to remind all of you to put the mic off during the talk of Rebecca. So after the talk, we will have some time for discussion and questions. So thank you again, Rebecca, and the floor is yours.
Thank you very much, and thank you for the kind introduction. I'm very much looking forward to telling you today about some of the work that I've been doing with my group over the last almost 20 years or so now, where we've been using neonatal neuroimaging to try and address a clinical challenge. And the reason I became interested in neuroimaging was because at the time when I was sort of starting my work, there was a real problem in terms of the best ways to measure and treat pain in babies. And I'm going to tell you about the journey I've been on over the last few years trying to address this question, and then tell you about some more recent work where we've been using structural and functional MRI to try and unravel some of the challenges related to the measurement of neonatal pain. So what is the challenge? Well, broadly, babies can't talk. And whereas if we were going to ask an adult if they were in pain, they would just verbally describe it in terms of the intensity, the location, the duration of the pain. And they'd also describe whether treatments were working and effective. But a baby cannot do that, and therefore we can never know whether a non-verbal person is experiencing pain. But instead, we use a range of proxy measures to try and get an insight into the type of responses a neonate would have if they were experiencing something acutely painful. And the majority of these measures are described on this slide, and I've highlighted a few in yellow because they form the basis of most clinical pain assessment tools. And the main approach people use is looking at changes in facial expression. And simply, if you do something that's acutely painful to a baby, the likelihood is that they will cry, and you can record these changes in facial expression through visual observation. You can also see different autonomic responses, such as increases in heart rate or drops in oxygen saturation, as well as different body movements. But there's a real challenge using these approaches. And there are two specific things I'm going to talk about. One is they lack specificity. So a baby will cry and mount many of these responses for reasons that are nothing to do with pain. For example, if they're hungry or they're distressed for other reasons. And also, they're not very sensitive. And by that, I mean the grading that you might see in a facial expression can be difficult to encode. And this becomes particularly important if you want to start using these kind of measures in order to decide, for example, whether or not to administer some drugs for pain relief, and particularly if these drugs are associated with potential side effects. So I'm just going to describe one study which outlines some of the challenges that I've just described. So here we've taken a population of babies from 28 weeks gestation. So this is just over sort of halfway through a normal gestation pregnancy when the baby has been born prematurely, up until around 40 to 42 weeks, which is equivalent to a term baby. And here we've looked at the proportion of the babies who respond with a change in facial expression to a clinically required procedure. And in this case, the procedure is a blood test where the foot is lanced in order to take a blood sample. And what you can see in red, in the youngest infants, around 50% of the babies have a facial expression change. And as these babies mature, you can see that nearly 100% of the babies will cry when they're sort of term age, and you will observe these facial expression changes. However, if you rotate the lancet by 90 degrees, so the baby has exactly the same experience as if the blade was going into the foot, but the blade doesn't penetrate the foot and therefore they don't get the noxious stimuli, you can also look at the same proportion of babies who are having a facial expression change. And what you see in the 28-week gestation infants, around 50% of them will still show these facial grimacing. However, as these infants mature, the chances of getting this observation in a term baby is much lower. And you can see there's a clear difference in the percentage of babies that will show this observation in the term age. However, if you start looking at the children that are below 33 weeks gestation and you wanted to use facial expression to discriminate between a painful and a non-painful event, you can clearly see that this would be a challenge. And therefore, you could potentially come to erroneous conclusions if you are using these kind of metrics to assess, for example, the analgesic efficacy of a known intervention. And so one of the questions we want to ask is, can more advanced neuroimaging techniques help us unravel why these differences are there, when they emerge, and indeed whether we can find more sensitive measures to look at pain expression in a baby. So the kind of measures that I've described manifest very different levels of the nervous system. If we're looking at the kind of body movements and reflex withdrawals, you can measure that using EMG put on the biceps femoris, for example, and this is being manifested by the spinal cord. Certainly a lot of the autonomic responses, such as the ECG and respiratory changes, can be observed. But these are not directly related to the sensory experience. And so we're interested in looking at the changes in brain activity because in the absence of language, the brain is the organ where the experience of pain is created. And therefore you might argue that this might be closer to a pain experience compared to downstream motor activity that is not directly linked to the perception. So I'm going to tell you sort of a 40-year journey really and highlight a few events along the way that tells you some of the work we've been doing to try and use brain imaging to unravel some of these challenges. And certainly some of the history in this area is rather checkered. So back in 1986, it wasn't uncommon for babies to have surgery performed without adequate pain relief. They were at times given muscle relaxants rather than analgesics in order to prevent them moving to facilitate the surgery. And there are a number of reasons for this. Primarily, it was due to concerns about potential side effects, but also there was a lot of question in the literature as to whether babies could really experience pain or whether the responses that were observed were just reflex responses because of their immature nervous system. Certainly, this changed, and it was in 1987 where many of these surrogate measures, such as the facial expressions that I described, started to be used to quantify pain. And then a lot of work was done really trying to understand the neurophysiological basis of this by doing comparative studies between rodents and humans. It was in 2006 when some of the work I'm going to tell you about started, and this is where we started to measure noxious evoked brain activity from newborn infants, initially using near-infrared, then EEG, and more latterly fMRI. And it was around the same time as this that people really started to understand some of the long-term consequences of having a high barrage of nociceptive input into a very vulnerable and developing nervous system, and how this could affect pain in later life. So I'm going to tell you a little bit about how we then went on to use fMRI to try and look at the type and location of the changes that we could see when babies had a noxious stimulus applied to them, and then how these measures can be used in clinical trials to better understand the analgesic efficacy. And through improving and developing these methods, one of the questions I'm really interested in is whether we can use them to better understand individual pain variability. So how do we do this work? Whoops. Oh, So how do we do this work? Here's just a brief video of the kind of approaches we use. It's a team of engineers, scientists and clinicians who work in the neonatal unit at the John Radcliffe Hospital. And we use a range of neuroimaging techniques, primarily when babies require a clinical painful procedure. So this could be blood tests, cannulations or immunizations. Then we go on to record these changes of brain activity in response to both noxious and innocuous events, such as matched auditory or visual stimuli. And the aim is to see if we can understand the differences in activity evoked by something that is noxious versus something that is perhaps comparative in terms of causing arousal, but doesn't have that noxious stimuli. And so to do that, there are a number of different approaches. One has certainly been to develop some bespoke methods that are suitable for neonates. So historically, many of the methods that have been used in neonates for MRI have just been downsized from adult methods, where we've tried to develop some new analytical tools to better understand this. The example image that you can see here is a post-mortem image taken at 7 Tesla in a 29-week gestation infant. And we're hoping to create a publicly available atlas across all gestational ages, where we can get a real understanding of the structural architecture of these neonates. The methods development is coupled with some basic neuroscience. So how can we better understand the basic underpinnings of pain, and when does it mature and develop? And then to start asking some interesting questions associated with that. For example, how does early life inflammation moderate these responses? And ultimately, what we want to do is be able to translate these kind of methods into a clinical setting. So can we use them to test the efficacy of interventions? We're going to tell you a little bit about some work we did trying to assess the efficacy of morphine, also non-pharmacological interventions such as maternal touch. And ultimately, would it be possible to have some of these measures approved through regulatory agencies so that we can develop better analgesics in neonates? The challenge here being that there are no analgesics licensed for infants less than 3 months old. And in part, I think it's because the measures we have to assess the efficacy of these interventions is not good enough. So these are the type of topics I'm going to talk about. We're going to talk about pain vulnerability. We're going to look at how pain matures from the infant to the adult, and also early life pain and how the interaction between the brain activity and behaviour can be better understood. So the very first studies that we did were really quite simplistic. We placed some near-infrared optodes on the infant's head, and in response to a heel lance, we looked at changes in the total hemoglobin concentration in the contralateral and ipsilateral somatosensory cortex. And what we observed in the majority of infants, that there was an increase in total hemoglobin concentration in the contralateral somatosensory cortex, suggesting that this noxious input was being transmitted to the brain. And we observed this even in the youngest infants. And while this seems quite straightforward, at the time, there was a lot of question as to whether this information was being transmitted to the cortex. And in part, that was because histological studies were suggesting this was also around the time when the pathways, say, between the thalamus and the cortex and other association pathways were beginning to form. So it was interesting to see that these responses appeared to be transmitted to the brain. We wanted to see how this corresponded to the kind of clinical pain measures that were being used. And it was pretty good. If you look at the relationship between the change in total hemoglobin concentration and the facial expression scores you can get from these clinical pain scores, the correlation was pretty high. However, what was interesting here, in around 40% of the babies, and this is similar to the graph I showed you earlier, they don't have a change in facial expression. Yet, even though they weren't mounting this facial expression change, in the majority of these infants, nearly 80% of them, we were still able to see this change in brain activity. suggesting this dissociation between the changes in brain activity we could observe and the behaviours. And certainly many groups are trying to better understand why behaviour or responses are not always manifest in response to a procedure. And for example, one of the observations we've seen is in children who are sick or septic, they are much less likely to mount a behavioural response, even though their changes in brain activity seem to be greater. But in order to better understand this, we wanted to look at the neurophysiological basis for some of these responses, and therefore started using EEG in order to look at these changes in brain activity. And here, some work that we did last year. We compared the changes in brain activity that could be observed using EEG with the responses to visual, auditory, and tactile stimuli. And in order to try and get the best match between the kind of modalities, which is a real challenge because you can't do anything to a baby that is noxious, that isn't required, we matched the intensity of the stimuli so that they had a similar physiological response. So even though flashing a light to a young baby will cause their heart rate to rise by a few beats per minute, or a loud noise could do the same. So they were matched in terms of the arousal. But what we saw is this late deflection that occurs at around 500 milliseconds only appeared to be present in response to the noxious input compared to the other modalities in term babies. And when you apply a treatment such as local anaesthetic in this case, it reduced the magnitude of this response. So we considered that this late deflection that you can see in red here to be a measure of noxious evoked brain activity that we haven't seen in response to other modality stimuli. Whereas an earlier deflection you can see in blue here could be seen across the different modalities. So one of the questions is, can we combine all of the different measures that we have, including changes in brain activity, also the important observations of behaviour, with the physiological responses such as the heart rate and changes in respiratory rate and reflex responses, to try and get the best composite understanding of how a baby will react in response to a procedure. And if we can do this, can we use these responses to better understand the efficacy of different analgesics for a whole range of different clinical procedures? And I think this is important because if you come back to the first slide where I described the behavioural observations in the most preterm babies, what you can see is even though we saw a reduction in the noxious evoked brain activity when the local anaesthetic was applied to the foot, because these babies will often cry anyway, just because of the distress and not just the noxious input, even when you apply the local anaesthetic, you don't necessarily see a difference in behaviour. And so perhaps by using these more advanced methods, we can begin to try and understand some of the different components that make up the response to pain in a young infant. And if that's possible, then we can go on to see whether interventions are able to reduce these patterns of activity. So here, I'm just giving you an example of one study where infants were either stroked at a speed of 3 centimetres per second or not stroked prior to a clinical heel lance. And the reason 3 centimetres per second was chosen as the optimal speed is because in adults, they report that if you stroke at this speed, it reduces their pain experience. And this is because there's a set of nerve fibres called CT fibres, which are optimally activated at around this speed, which are thought to be to do with social bonding. And so by doing a study like this, we could compare the stroking versus the no stroking condition. And what we were able to see is this reduction in noxious evoked brain activity in these stroked infants. I can go on and give you some other examples of pharmacological interventions later where we've used a similar approach and outcome measure. So hopefully I've convinced you that we can see changes in brain activity in response to a noxious stimulus. And one of the questions we wanted to ask using MRI was, where in the brain are these responses occurring? And this was really a very straightforward observational study. 10 adults and 10 infants were put in a scanner, and we applied a mild noxious pinprick stimuli, is the trade name, and it's a mild force of 128 millinewtons that's applied to the surface of the skin that's at an intensity that's low enough not to mount a behavioural response to the stimuli. But it does cause a very small heart rate increase of 1 or 2 beats per minute, and the stimulus is noxious, so you can make these changes. And in doing that, when you just visually look at the differences between the responses you could see in the adults, when they described the stimulus as being painful compared to the infants, you can see that there's a very similar pattern of activity. And lots of the brain areas that we see active in the adult, such as the somatosensory cortex, the thalamus, the anterior cingulate cortex, were also present in the infants. But indeed, there are also differences. The infant activity seems to be much more bilateral and more widespread. And certainly there were some areas in the adult where we were not able to record activity in the infant, such as the orbital frontal cortex. But we didn't do any quantitative analysis here because the methods were really quite crude. So in order to really build on this observation, we needed to improve the pipelines that we were using for the analysis of this data. And the reason is that the neonate is simply not a downsized version of the adults, and there are many different challenges that need to be addressed when doing neonatal brain imaging compared to adults. And I've just given a few examples of the type of challenges we wanted to overcome through developing these new pipelines. The babies move more and in a different way. Their brain hemodynamics are different to the adult, they're more sluggish, and so you have to use different hemodynamic response functions. The contrast between the adult and the infant in terms of tissue contrast is completely different. And of course, even in an infant over just a few weeks, and in this example, we're going from 36 to 42 weeks gestation, there's huge variability in size. And so by developing methods in collaboration with the Developing Human Connectome project to better account for some of these differences, we were able to refine the neonatal pipeline. And you can see in doing this, when we applied the adult pipeline to the neonate, we had much more limited activity compared to the neonatal pipeline. And in subsequent work, it's this neonatal pipeline that's been used to really get a better handle on some of the relatively crude observations that were made in the first fMRI study. So this is an example of the type of activity we can now see when we use these improved measures. And this is a group of 18 babies that baby has been placed in an MRI scanner. And as I said before, a mild noxious stimuli is applied to the baby with an interstimulus interval of around 20 seconds, and approximately 10 times the stimuli is applied. And again, you can see really clear and delineated activity in areas of the brain that we would expect to see active if we applied the same stimulus to the adult. For example, the insular cortex, the paracentral lobule, and the thalamus. You can see clear delineation. So, having got these comparisons, can we do any more than just this qualitative, they look kind of similar and there are some differences, which is what we broadly stated in this first study? So what we did is we worked in collaboration with Tor Vega. Many of you might know that Tor Vega has developed a series of neurological pain signatures that quantify pain in the adult, that are sensitive to analgesic administration, they encode with intensity, and they have other features that where they're considered robust signatures of the type of brain activity you'll observe in an adult. And so we wanted to see is if we took these adult signatures and morphed them so that they were suitable for use in an infant, would we get similar patterns of activity, or would they differ between the infant and the term baby? And what you can see here is when we applied these neurological pain signatures to the adults, as expected, they encoded stimulus intensity. So here the intensity of the stimulus is going up, and the representation of this signature in the brain in the adult increased. When we applied these to our infant cohorts, and we did this in 2 different cohorts across 2 different scanners, we saw similar changes in activity. And so we concluded that the neural infrastructure was in place in the adults to encode stimulus intensity. But further work by Torvega and his colleagues also developed a number of different signatures. And here I'm going to give you an example of one called SIPS1, which is a stimulus intensity independent pain signature. So here it's been altered so that it doesn't encode stimulus intensity, but it encodes other aspects of the pain experience. And what we were able to see is that this is well encoded in the adults, but we didn't see this signature in the infants, suggesting some differences between perhaps the basic sensory encoding that we could see in the neurological pain signature compared to the features that were best quantified in the stimulus independent signature, which relate to perhaps some of the more effective components of pain. So in doing this, it comes back to some of the questions I said I was interested in the beginning. Can we use some of these approaches to better understand the differences that a newborn baby within the first couple of days of life will have in response to the same intensity stimulus? And can we understand some of the factors that are driving these changes? So, for example, the impact of early life experience or pathology. How does this change the intrinsic brain organization? And if we can understand this, how does that relate to the pain-related brain activity and behavioral observations that we can make in the clinical setting? And this is just an example of 3 infants from the study where the same stimulus has been applied to them, but clearly they have very different amplitude maps. So one of the first studies we wanted to do to see if we could explain this was to look at the influence of the descending pain modulatory system. And the reason we were interested in this is that in adults, some work had been done that showed that the amount of pain-related brain activity that could be recorded was dependent on the connectivity of this descending pain modulatory system in the pre-stimulus period. So if there were better connectivity across some of these areas that are thought to be involved in pain modulation, then the response in terms of the overall magnitude of the noxious event response decreased. We wanted to know if this was present in term-born infants. And what we found is actually the pattern of activity was really similar. So adults and babies seem to have increased connectivity across the RVM and the PAG and the other areas, and anterior cingulate cortex you can see here. If these were more connected in the pre-stimulus period, it seemed that the magnitude of the responses evoked by these stimulus were reduced. And this is an interesting question because when we have looked in the clinical setting and going back to these EEG and reflex responses, there's a lot of evidence to suggest that this descending modulatory system matures later than the ascending system. So for example, these noxious evoked patterns of EEG activity I've been describing seem to increase in magnitude as the infants get older. And in parallel, the reflex withdrawals that we observe in the youngest infants are much less well coordinated in the younger infants. And as they mature, they have a decreased magnitude and latency of these responses. And so we've been looking at the relationship between these changes in brain activities and this control of these body movements. And we're hoping to think about how brain imaging might be able to us to better understand these observations. So this is an example of the activity maps in the 18 infants that I described earlier, where we could see the noxious evoked brain responses. And you can see that there's this large variability in terms of the responses from very low to high responses. So can we better understand why there's some variability, and can we relate this to the structural and functional architecture of the neonatal brain? Well, first, we want to be sure that this isn't just some artifact of the analysis, and a lot of work was done to show this. This is just one example that shows that the hemodynamic response function fits were equally as good when we had these negative responses versus these positive responses. So we did a lot of work to be confident that the differences we were seeing was real physiological differences rather than differences due to image processing. And the question was, can we relate these evoked responses to the resting state networks? And so we identified 9 resting state networks in our local Oxford dataset with just these 18 babies that we also were able to observe in a large dataset from the Developing Human Connectome project. And as you can see, the reproducibility between the different sensory networks and higher order networks was quite robust. And then the question is can we look at whether these resting state networks could predict the response to the noxious stimulus that we observed? And what we found is that there was a really high correspondence, as has been observed in adults and across many different modalities, between the resting state activity and the noxious evoked bold response. And in particular, it looked like the somatomotor networks was the primary driver of this response. So this suggests that the underlying resting state activity can be used to give us some insight into the expected responses that we might observe to when the baby is stimulated. In addition, we also wanted to see whether it was possible to relate this back to the underlying white matter microstructure. And here we took some models which we developed again in the large data set with the DHCP data, and then tested them in our local data set. And what we found is that the mean diffusivity coefficients in 5 of the bilateral white matter tracks seem to significantly relate to the noxious evoked response amplitudes. And furthermore, they suggested that greater myelination or fibre packing density in neonates was associated with these larger response amplitudes. So one of the questions is if we know that the resting state of the brain in the first few days of life and their structural architecture is predictive of the responses that we're seeing in MRI, is it also predictive of the responses that we see with EEG and indeed some of the behavioural and physiological variability? And this is a question we're now aiming to ask, because whilst this is very interesting from a better understanding of the physiological of the brain, we're really interested in bringing these techniques into a situation where we can use them for in clinical practice. And of course, MRI is not going to be able to do that. And so just as an example of some recent work we've been looking at, which have kind of been based on this idea that we can get an understanding of how a baby will respond or which treatment options they will respond to by understanding their background brain activity, we've been applying a noxious stimulus to the baby while they're in a baseline state, quantifying their responses and looking at how this maps on to responses to clinical procedures. And one of the huge upshots of this is that by accounting for this huge amount of variability, we're substantially able to reduce the number of infants that you might need in a clinical trial if you wanted to address this question. And the reason for this is that a lot of the variability is then accounted for that you will then see in response to the clinical procedure, and can allow us to do clinical trials with the minimum number, which is obviously an ethical requirement. So this is just an example of how we can start to use these relationships to test analgesics. In addition, one of the other areas that we've been looking at is, of course, we alluded to earlier that we're interested in the long-term consequences of this early life pain. But after the neonatal period, up until sort of 5 years old, when a baby can reliably lie, a child, sorry, can reliably lie in a scanner and not move, there really is a limitation in terms of using MRI in this period. And so can we also develop measures using new technology? In this case, it's the OPM MEG imaging technology, to look at the changes throughout this period so that we can start to track these children. And this is just an example of some of the technology that's being developed in this area. So finally, I'm just going to give a quick overview of a clinical trial where we were looking at the analgesic efficacy and safety of morphine in a randomized trial. And it's an example of how the EEG responses can be used to better understand the intervention effect. So just as a very brief background, retinopathy of prematurity is an eye condition that affects premature or low birth weight infants. And the blood vessel supply to the retina is not fully developed at birth, and therefore the eye blood vessels can grow in a disorganized way, and this can lead to problems with vision and blindness. And therefore a screening program is in place that's international programs where babies are regularly screened for retinopathy of prematurity so that treatment can be given and these sight problems are reduced. So what we were doing here is taking all babies who are born at less than 32 weeks gestation or weighed less than 1,500 grams who were having this eye screening done, which is done on a 1 or 2 weekly period during their hospitalization to ensure that their eyes are developing normally. But the challenge of this is that it's considered to be painful. Current analgesic options are considered inadequate. There have been many studies looking at the impact of sucrose, local anesthetics, breast milk, cuddling, paracetamol, for example. And not only is it painful, it's also quite destabilizing for the infant. So in the 48 hours after these eye screens, babies are much more likely to have unstable breathing. And so they're more likely to have new onset apnea. They are tachycardic, so they have a very high heart rate during these procedures. And then afterwards, they often have periods of bradycardia, which could be associated with the stressful experience. So what we wanted to do is to see whether providing morphine during this period, procedure at a dose that was clinically being used in our neonatal unit and was recommended in different formularies would reduce the pain associated with the procedure, and also whether it would reduce the instability that was seen afterwards. Well, we were going to study 156 babies, but we stopped after 31 infants. And this is because the trial steering committee and data monitoring committee considered that on balance, it was potentially the case that the morphine was causing harm. And this is the kind of data that they were looking at. So this is an example of a single baby in the trial. You can see we monitored their heart rate for 24 hours before the procedure and 24 hours afterwards. And we quantified when they had these periods of instability, so bradycardias or tachycardia, which you can see straight after the event here, and also decreases in oxygen saturation, where they were having profound desaturations. And you can just see if you take the 12 hours before versus the 12 hours after, in this baby who was given morphine, there was an increase in their instability, and the count rate for their profound oxygen desaturations and apnea substantially increased. And as a consequence of this instability, the data showed us that in 5 of the 15 of the morphine-treated infants, they needed an increase in respiratory support post-procedure, whereas in the placebo-treated infants, they did not require this increased respiratory support. And therefore, it was concluded that this dose of morphine that was used was not appropriate. So the trial was very much underpowered in order to look at whether the morphine altered these brain-derived behavioural measures and reflex measures that I've described. But even in this small sample size, what we could see, if we compared these metrics between the morphine-treated and the placebo-treated infant, there was no suggestion that the morphine was reducing the reflex activity, nor the brain activity, or nor the facial expression. And in fact, even if we wanted to repeat this trial, we couldn't power it on this data because across all these metrics, there was a slight reduction in these measures in the placebo-treated infants. So we concluded that the administration of oral morphine at 100 micrograms per kilogram to non-ventilated premature infants had the potential for harm without any evidence of analgesic efficacy, and therefore recommended that morphine was not given at this dose to non-ventilated premature infants for retinopathy of eye screening. And so this is just kind of showing you the type of directions we can go in if we use these brain-derived approaches as outcome measures in clinical trials. But certainly a lot more work needs to be done here, because here I'm just giving some summary of some different drugs or non-pharmacological interventions that we've looked at, such as sucrose, paracetamol, morphine, and brushing. And we know that these interventions are differentially modulating brain activity and behaviour, and we need to better understand this. For example, we haven't found evidence that sucrose reduces changes in brain activity, but it does seem to diminish their clinical pain scores. In contrast, paracetamol seems to reduce the changes in brain activity that we observe, but there's no suggestion of a reduction in behaviour. Morphine, we didn't have evidence either way, and again, there's similar differences with non-pharmacological gentle touch, which we're now investigating a bit further in a new clinical trial called the PETAL trial, where the parents are going to stroke their infants. And importantly, we also get feedback from the parents in terms of whether it improves their bonding and well-being, being able to be more involved in their infant's care. So just to summarise what I've said, I think brain imaging has a great deal of use and understanding in terms of clinical applications. One of the clear challenges as we have in neonates is it's difficult to treat pain in this population, and we are dependent on surrogate measures in order to best quantify pain if we want to try and treat it or develop drugs. And currently, drugs are being prescribed off-label for this population, so we need better endpoints. And I think brain-derived metrics could potentially provide this. If we're going to do this, we need much better collaboration between academics, industry, and regulators so that we can get validated endpoints that are adopted by different regulatory agencies. As an example, pharma have done clinical trials looking at the sort of efficacy of drugs, paracetamol, for example, and they were able to show that it can reduce fever in infants because it reduced the temperature when paracetamol was given, but they're not able to show that it has any efficacy on pain because, again, it may be that the measures that we're currently using aren't sensitive enough. And so hopefully we can start to use some of these approaches to really refine and validate and try and get better endpoints that could be used for these populations. And currently we're working with the European Medicine Agency and others in the FDA to really try and think about the best way to go in order to improve the evidence base to enable these kind of collaborations to begin, and certainly for these sort of conversations to start. And so finally, I just thank all of the fabulous people that have been doing all this work while I get the pleasure of telling you all about it. Thank you very much.